journey continues, and I know I'm not alone. Because together we can make a difference every day.
Good morning, everybody, ladies and gentlemen. On behalf of organizer committee, we would like to say ceremony opening this session. This morning, we have scientific sessions with 9 scientific reports from many countries: Vietnam countries, Indonesia countries, China countries. This morning, I am Quân Nghiệp Phước Bảo. I have chairpersons with Professor Hwan Seong Yong. I hope that everybody in the webinar conference receives many information useful for your jobs and can practice daily in your jobs every day. Now, I would like to introduce the first report from Vietnam countries. The name of the topic: subclinical changes in cardiac functions detected by spectral tracking echocardiography in the patient with systemic hypertension. Reporter is Dr. Nguyễn Thị Diễm. I had a little bit some work introduce about the reporter. Dr. Diễm from the Faculty of Medicine, Cần Thơ, University of Medicine and Pharmacy, Cần Thơ University Hospital. This is a general hospital of the Cần Thơ city in the north of Vietnam. This is the big city in the Mekong Delta. She is a cardiologist. About the academic appointment, in 2012, she received a certificate echocardiography at Hanoi Medical University. In 2013, She received a certificate of Holter echocardiogram blood pressure in Hanoi Medical University in 2020. She received a certificate of echocardiography in Institut Cœur de Ho Chi Minh Ville. About her professional affiliation and scientific publication, she is the author of many articles in the 4 main journals in Vietnam. Now, I would like to invite Dr. Diễm deliver your report, please.
Hello. Today, I would like to talk about the research clinical changes in cardiac function detected by spectroscopy echocardiography in the patient with systemic hypertension. Systemic hypertension has become one of the most rapidly growing cardiovascular disease in many countries around the world. It was estimated the prevalence of hypertension in the world around 14.5% in Vietnam. After 26 years, the prevalence of hypertension increased 3 times. Hypertension causes lots of complications such as cardiovascular, brain, kidney, and eye, and the cardiovascular death still remains high. In clinical practice, to evaluate cardiac function, there are many techniques. Classical techniques, we have more two-dimensional Doppler, but these techniques were angle-dependent and semi-quantitative methods. They detect in a single plane. So, classic method can assess the myocardial abnormality in the late stage of hypertension. Nowadays, spectroscopy echocardiography is a new technique with independent angle and objective results, global function. That's why this technique can evaluate the cardiac abnormality in the early stage of hypertension. The aim of this study to evaluate the early changes in left ventricular systolic and diastolic function by SDA in the patient with systemic hypertension. This was processional repetitive study consists of 151 hypertensive patients and 43 persons without hypertension as control group. The criteria for hypertensive group: primary hypertension according to Asci, ASH, VSA, and VSH, with echocardiography ejection fraction greater than or equal to 50%. We exclude the patient with heart failure, reduced ejection fraction, coronary artery disease, valvular disease, arrhythmia, and so on. Criteria for selection for control group: we choose the person without cardiovascular disease, no diabetes, no cancer, no pulmonary hypertension. Especially, the echocardiographic indicators were normal according to standard of American Heart Association. We exclude the patient with poor image quality. Analysis step. We record two-dimensional image in succession, and then analysis of myocardial angiogram by software with Philips company. First, select two points, and then the software automatically determine the endothelium and margin and give the myothelium information of each segment. On this figure, we were analyzing strength in longitudinal axis. Myothelium segments were plotted in many different colors. The global function of left ventricular were the average of 3 sessions, and each were represented a clock, or each were represented a full hours. In this graph, you can easily recognize uh, the function of every segment. In radial trend, circumferential trend, and physics, we evaluate in the transverse section at the base, the middle, and the apex. Situate function consists of global longitudinal strength, circumferential trend, and radial strength. Diastolic function consists of global longitudinal strength rate in the early stage and late stage of diastolic period. And after that, we export all the value to Excel and calculate the average strength. Longitudinal strength were the average of three longitudinal sections and the same with radial and circumferential strength. About the result of survey, in this table you can see there were no difference in age, BMI, heart rate, left ventricular muscle index, ejection fraction between the hypertensive group and control group. In this table, longitudinal strength, circumferential strength, and radial strength in hypertensive group reduced uh, than compared with control group. According to Kosmala, Timpalazano surgery also confirmed the same that. How about the systolic trend according to left ventricular morphology? Longitudinal strand, circumferential strand, and radial strand revealed in hypertensive patients without left ventricular hypertrophy and the risk reduction in the patient with concentric hypertrophy. Monaster also confirmed that these parameters decrease not only in hypertensive patients but also in pre-hypertensive. In the patient with grade 1 of hypertension, these values started to reduce and the risk reduction in hypertensive with grade 3. Yandersay also detect longitudinal strength decline in the very early stage of hypertension and even in pre-hypertension. How about in the patient with heart failure? These parameters reduce in hypertensive patients without heart failure and remarkably reduce in the patient with heart failure, and these values started to reduce from lab 1 to lab 2 according to New York Heart Association. Rayner and Kosmala survey also confirmed that these parameters were more severe from lab 1 to lab 4. About diastolic trend, they will decrease in global longitudinal strain rate in the early stage and late stage of diastolic period, compared with the hypertensive or compared with control group. And these parameters also decrease in hypertensive patients without left ventricular hypertrophy and no reduction in the patient with concentric hypertrophy. Hammett surgery confirmed that longitudinal strain rate decrease in hypertensive patients, and gradual decrease from normal left ventricular morphology and to left ventricular hypertrophy. In the patient, in hypertensive patients with heart failure, these parameters started to reduce, uh, and the more reduction in the patient with heart failure. Gardner et al. Also determined a correlation between longitudinal trend rate in the early stage and left ventricular relaxation. In conclusion, articulate function by SDA, longitudinal strength, circumferential strength, and radial strength decrease in the hypertensive patient compared with control, and P reduction occur in a very early stage when patients didn't have any changes in left ventricular morphology and function. Calculate function by SDA, longitudinal strain rate in the early stage and late stage, help to detect early abnormality in the absolute function in the patient without symptoms of heart failure and or any changes in the absolute function by conventional method. Thank you for your attention.
Thank you so much for presentation of the Dr. Yim. The next report, please.
Okay. I'd like to introduce next speaker. I'm Dr. Han Seok-yong from Seoul, Korea. Next speaker is Dr. Eun Wen Le Hwang Min. Dr. Min is Doctor of Medicine of Korea University of Medicine and Pharmacy. He will present about endocardial 2D spectral tracking echocardiography in patients with ischemic heart disease. Dr. Min, please. Okay, go ahead, Dr. Min.
Hello, I'm Dr. Nguyễn Lê Hoàng Minh from Huế University of Medicine and Pharmacy Hospital. Thank you for coming. Today I'm going to present to you my report on endocardial 2D spectral tracking echocardiography in patients with ischemic heart disease. Coronary artery disease is a common disease in developed countries and tends to increase rapidly in developing countries. It causes regional myocardial disorder. There are ways to detect and assess myocardial function and coronary lesions, including heart echocardiography, myocardial perfusion image, or stress test, and coronary angiography. This is the nomenclature of left ventricular myocardial segments with their distribution according to coronary artery territories. We have LAD, which means left anterior descending RCA, or right coronary artery, and LC is left circumflex. If there is any lesions and obstruction in each individual main coronary artery, will cause ischemia and abnormal motion in corresponding one as described in this image. So what is spectral tracking echocardiography, or 2D STE? It recently emerged as a quantitative ultrasound technique for accurately evaluating myocardial function by analyzing the motion of speckle identified on routine 2D sonograms. A speckle is a unique acoustic pattern resulting from the interaction of ultrasound energy with tissue. It provides non-Doppler, angle-independent, and objective quantification of myocardial deformation and left ventricular systolic and diastolic dynamics. By checking the displacement of the speckles during the cardiac cycle, strain and strain rate can be rapidly measured offline after adequate image acquisition. The term strain can mean stretching or deformation. Velocity and displacement characterize wall motion. Strain and strain rate describe wall deformation because different parts of an object move with different velocities. The object will undergo deformation and will change its shape. Thus, wall motion measurement cannot differentiate between active and passive movement of a myocardial segment, whereas deformation analyzing allow discrimination between active and passive cardiac muscle movement. How do we do it? The 2D SDE was performed in 2 chambers, 3 chambers, and 4 chambers views by checking the endocardial border from images with highest available frame rate. 2D SDE was also performed in the short axis to check the endocardial layer. Speckle motion was carefully inspected and segments with poor checking were manually readjusted and excluded if they exhibited persistently inadequate checking throughout the cardiac cycle. This is the presentation of 2D SDE on QLab software. The software automatically traced the endocardial border from the entire left ventricle myocardium and measured layer-specific GLS or global longitudinal strain and global circumferential strain. Simultaneously, coronary angiography was performed and reviewed by 2 experienced interventionists. Both were blinded with the echocardiographic findings. Diagnosis of significant coronary artery disease was considered when more than 50% reduction of vessel diameters appears. Here is on the image, you can see on the upper left corner, you can see the software automatically check the endocardial border. Also, on the lower left, we have the strain rate calculated and presented on a graph. On the right-hand side, we have the nomenclature of cardiac muscle and strain rate presented on it to help the physician to easily imagine the location of the wall motion abnormalities. So we have 2 questions. How are the parameters of endocardial strain on 2D SDE in patients with ischemic heart disease? Is there an agreement between 2D SDE and coronary angiography on the coronary lesions? To answer that, we have 60 participants of the average year from age from 60 to 70 years old. Hypertension and smoking are risk factor, and also dyslipidemia. We observed the change in left ventricular function by 2D SDE. We have the result of strain rate in healthy individual. Average strain rate, longitudinal strain rate assessed by 2D SDE is in the range from -18 to -20. In this table, strain parameters decreased in comparing to the normal value. The myocardial fibers most susceptible to ischemia are the longitudinal oriented fibers that are located subendocardially. Measurement of longitudinal motion and deformation are therefore the most sensitive markers for coronary artery disease, despite the left ventricle ejection fraction is preserved. We also have the correlation of the strains and ejection fraction, which has statistically significant. We also assess the agreement between the 2D SDE and DSA or angiography. In this table, we compare the wall motion abnormalities on 2D SDE and the coronary artery lesions. For the significant coronary stenosis, the agreement of diagnosis between 2D SDE and DSA with kappa equal to 0.34, 0.53, and 0.24 respectively in septal, lateral, and inferior walls. we found that the agreement between 2D SD and angiography is not good with the endocardial settings of QLab software to identify the segmental motion abnormalities clearly viewed in 2D echocardiography, but may not be recognized on the endocardial 2D SDE. The epicardial strain analysis may resolve this problem in these cases if we change the layer setting on the software. Conclusion. The study using endocardial strain on 2D SD shows the reduced left ventricular systolic function in patients with coronary artery disease. There is a various agreement, which is not great, about the location of coronary lesions between 2D SD method and coronary angiography. I humbly thank you for your attention. If our respected guests have any questions, I would like to try my best to answer. Thank you again.
Okay, thank you, Dr. Min. Is there any comment or a question? If there is no comment, I'd like to move to next speaker. Unfortunately, third speaker will not attend this session, so we will move to the first speaker. Professor Kwan, please.
This is the next report. I would like to introduce the next topic this morning. The name of the topic, successful device closure of a large rupture of the sinus of the vascular in patient with bicuspid aortic valve. Reporter is Dr. Nguyễn Thị Minh Lý. Follow is a CV of the Dr. Nguyễn Thị Minh Lý and the current affiliations. She from the Hanoi Medical University. She is a lecturer and she works in the Health Center, Hanoi Medical City University Hospital, and she is vice director. Her specialty is cardiology in adult and pediatrics, echocardiography, pulmonary hypertension. Academic appointment from 2009 to now. She is a lecturer. She worked at the cardiology department, Hanoi Medical University, 2016, and now she is a vice director, Health Center at Hanoi Medical University Hospital. She is author of the book chapter hypertension in published in 2007 in Vietnamese language. The second book is Clinical Cardiology 2012 in Vietnamese language. Now I would like to introduce Dr. Nguyễn Thị Minh Lý. Please.
Hello everyone, I am Dr. Lý Nguyễn from Hanoi Medical University Hospital, Vietnam. I would like to thank to the Asian Society of Cardiovascular Imaging for allowing me to present our case. Successful device closure of ruptured sinus of ventricular aneurysm in a patient with bicuspid aortic valve. Here are the authors who took part in treating the patient. None of the authors have anything to disclose. Let's start with the clinical details. This is a 61-year-old man. He had no known history of any heart disease. He developed progressive dyspnea on exertion 1 month, and he was sent to a hospital where they treated his heart failure and sent him to do echocardiography and multi-slide CT, and that with the diagnosis of ruptures of sinus of ventricular aneurysm into right atrium. moderate bicuspid aortic valve stenosis, and dilated ascending aorta. After stabilized his heart failure, he was indicated to have an open heart surgery to repair the rupture. However, his family didn't want him to have an open heart operation, so they moved to our hospital for the second consult. At our hospital, they booked to meet with our professor, who is very experienced in intervention congenital heart disease, and he sent him to do again the transthoracic echo. And here is his imaging. On the first movie, you can see the bicuspid aortic valve, short axis view with calcified leaflet and mildly restricted opening. The pressure gradient across the valve is 46 above 27 millimeter mercury. And at the position of 7 o'clock, you can see ruptures of the right sinus of Van Sava from into the right atrium. With the diameter, we can measure at the aortic end of the rupture is around 11 millimeter. And on the subcostal 4-chamber view and the 5-chamber from the apical, you can see very clearly the rupture shape like a windshock-like, and the shunt go through from the aorta just above the valve into the right atrium very clearly. Let's know something about our heart center. Our heart center is very experienced in structural and congenital intervention. My Professor Nguyễn Lân Hiếu, and his team have done hundreds of cases of left to right shunt device closure, including VSD, ASD, PDA closure, and all kinds of fistula closure. One thing, we just use transthoracic echo to check during the intervention, and we do not use transesophageal echo. So for this patient, our plan was aortic angiography for him and try to device closure the ruptures of Van Sava. The patient was sent to the cath lab the next day, and when we angio him on aortography, you can see the contrast comes from the aorta to the right atrium, and we can measure the narrowest size of the ruptures around 8 millimeter. So our professor decided to use a PDA device with the size of 2018 size. We use the antegrade way to deliver the device. We check the device with a transthoracic echo, and we see the device is well seated and very little shunt. So our professor decided to deploy the device, and immediately we do the angio again, and we see just a little trivial residual shunt through the device, and the device is no compression to the coronary artery and cause no AR. We do the transthoracic echo the next day to check the result of the intervention, and you can see you can see the device is well seated and no residual shunt across the device. The aortic valve has no AR, and interestingly, the gradient across the aortic valve reduced greatly to 18 above 12 millimeter mercury. We can see more clearly the device in the subcostal 4-chamber view and apical 5-chamber view. The device caused no restriction to the aorta movement. About his clinical, he can walk around the next day. He had no symptom, no dyspnea at all. On auscultation, we can hear soft ejection murmur, and he also had clear colored urine. We also did a Holter EKG for him, but found no arrhythmias, on-time sinus rhythm. The patient was discharged on the day 2nd, and he was on aspirin 100 milligram daily. He overall very well and have a first time checkup after 1 month. He no longer had any dyspnea and have weight gain. So the learning points from our case, with a patient with rupture subsinus of van Sava in a patient with bicuspid aortic valve, the rupture the aneurysm can be ruptured, and in that case we have two option treatment, maybe surgical conventionally or intervention. And one thing is the bicuspid aortic valve stenosis may be overestimated in the patient with ruptures, and the gradient across the valve will reduce after we close the rupture. And we can think of choosing intervention for the patient if the center is very skillful in doing intervention for congenital heart disease. By choosing intervention, your patient will have great benefit of no valve replacement, and he had short hospital stay, make a full and rapid recovery, and less complication. I would like to thank you for your listening, and once again I would like to thank the Asian Society of Cardiovascular Imaging for allowing me to present the case. Thank you.
Okay. Thank you. Thank you. I'd like to introduce next speaker. Please, next speaker. Yes, thank you. Next speaker is Dr. Kana Kroniati Elka from Indonesia. She is a cardiologist working at Telegraduate Hospital since 2018. She have various publications such as the pulse rate velocity is linear correlated with the resting systolic and diastolic blood pressure in hypertension patients, and malignant early repolarization syndrome, first case reached in Indonesia. Today, Dr. Elka will report the dilated IVC without cardiac pathology, the first case in Indonesia. Please, Dr. Elka.
Hello everyone, good morning. My name is Kana Elka from the Department of Cardiology and Vascular, Semarang Medical Center, Telegraduate Hospital, Semarang, Indonesia. Today, I present my case with the title Dilated IVC Without Cardiac Pathology, the first case in Indonesia. As an introduction, inferior vena cava is a large collapsible vein whose diameter and extent of inspiratory collapse are known to correlate with right atrial pressure. The inferior vena cava dilatation represents a cardiac pathology. This case report emphasizes that IVC dilatation may not always have an underlying cardiac pathology. As a clinical recommend, I still recommend to do the anamnesis physical examination, reading the ECG, chest X-ray before we do the echocardiography and CT scan, because in my practice, the clinical lesson is interesting. As a patient, 28 years old female, was referred to our cardiology clinic for an evaluation of a dilated AVC that I incidentally note on abdominal ultrasound. She has a complaint, the shortness of breath, and lower abdominal pain, sometimes have a chest discomfort, but she don't have a characteristic chest discomfort. As a history of curated 3 times due to miscarriage. She don't have diabetes, hypertension, dyslipidemia, and have a normal BMI. As the physical examination, have a blood pressure 102 per 56, the heart rate is 78 beats per minute, have a lower right abdominal pain on palpation. And about the cardiac is normal. This is the ECG. The ECG is looks like a normal, have a sinus rhythm on the 75 times per minute. This is the X-ray, and on the X-ray we can see the cardiomegaly. Cardiac waste is missing. And then we do the echocardiography. As an echocardiography, the result is a normal ejection fraction, have a left ventricular hypertrophy, eccentric, with the normal ejection fraction, 70%. And we do in the long axis and short axis. Here we can see have a tricuspid regurgitation, mild, and mild mitral regurgitation. And the first we can see this is the dilated size on 2.9 and 2.6 centimeters with sniff test. We do the coronary artery, CT thorax, and CT abdominal. And we have the abdominal results or an normal coroner. Have a dilated right ventricle, slightly dilated right atrium. Yes, we can see in here. Wait, yes. Have a dilated in the pulmonary artery. And we can see in here now have a dilated IVC. And we can see in the lower hemipelvic right have a numerous tortuous flow voids or a tangle of vessel, indicative of hypervascularization, the absence of a mass and the presence of flow voids confirm the diagnosis of arteriovenous malformation. We can see in the another view and have a same. This is a arteriovenous malformation. Have a hypervascularization in the right hemipelvis. And we transfer to the gynecology clinics. As a discussion, as the cardiologist, we always do the routine echo service. A lot of information when we assess about the IVC. On the IVC, we can see about the intravascular volume status and determine the right atrial pressure. And we can see about the volume status from the sniff test. The two mechanisms that may account for the dilatation is the first one is the development of the collateral channels as a result of venous obstruction or stenosis. The symptoms with the vessel dilatation vary according the level of obstruction. And the second is the increasing blood flow through the collateral vessel from the neoplasm or vascular lesion. As in our patient have a condition, usually the result of the trauma because the patient have a history of the abortion followed by dilatation and curettage. After malformation, increased uterine blood flow leads to the dilatation of the uterine arteries and venous plexus. The dilated fascia in the peripheral to the uterus may stimulate the collateral circulation. Tortuous and coiled vessels within a thick myometrium are a hallmark of the uterine affair malformation. A dilated IVC without a collapse with inspiration is associated with the worst survival in the patient with a history of the heart failure. We report a young woman with a normal ejection fraction and dilated IVC because of affair malformation of the uterus. This condition is rare, and to the best of our knowledge, this is the first case of the isolated dilatation of the IVC reported in our country. Thank you for your attention.
Thank you very much for your beautiful case presentation. So this is AV malformation of uterus cause the IVC dilatation. Is there any question or comment? Thank you. Thank you again.
Now we move to the next two topics of the Dr. Pham Thu Thủy. The first topic of the Dr. Pham Thu Thủy concerning aneurysm of the sinus of the vascular dissection into the interventricular septum, 3D echocardiography image. I would like to introduce a little bit Dr. Pham Thu Thủy. She comes from Vietnam. Her affiliation is the Vietnam National Health Institute, Bạch Mai Hospital. She follow the cardiologist academic appointment from 2016 to now. She worked in the Vietnam National Health Institute, Bạch Mai Hospital, Hanoi, Vietnam. She performed fetus to adult congenital heart disease, idiopathic pulmonary arterial hypertension specialty. She put book chapter of the one book and 2, 3 scientific report. And now I would like to introduce Dr. Pham Thu Thủy deliver her presentation.
Hello,
Please.
everybody. My name is Thuy Pham from Vietnam National Heart Institute. It's my honor to give presentation at Asian Society of Cardiovascular Imaging. Today, I will present a very rare form of aneurysm of sinus vasa that dissect into interventricular septum. So, first of all, I briefly review about literature of aneurysm of sinus vasa. Is an animal dilatation of aortic root that locates between the annulus and the sinotubular junction. It was first described nearly 200 years ago. About the causes, most cases are congenital, but sometimes acquired. The symptom of aneurysm of sinus vasa are usually silent, but sometimes acute when when complications happen. The main complications include arrhythmia, compression of giant aneurysm in two heart outflow tracts, even to coronary arteries, and aortic regurgitation is the most frequent complication. About management for small aneurysm and rupture with no significant error, conservative treatment is reasonable, but a surgical treatment is proposed in case of complications such as heart failure due to rupture of aneurysm into heart chambers, arrhythmia, or severe aortic regurgitation. Surgery is preferable for giant ASV with compression to attention structures. And now I will present my case. 9 a 59-year-old male was admitted with progressive development of dyspnea. His medical history was unremarkable, with no persistent fever, no edema. His clinical picture showed a significant diastolic murmur on left sternal border and an elevation of inflammatory markers, but blood culture were negative. His heart failure was clear due to elevation of NT-proBNP and bilateral pleural effusion. His EKG showed standard risk left ventricle hypertrophy without AV block. And now I show you his 2D echo on a parasternal long axis at the one third upper part of interventricular septum. We can see here there are a very mobile structure that may be connected to the right coronary curve. And here is with colored Doppler, we can see here there a blood flow that comes in and comes out of the structure, and my mitral regurgitation. At that moment, I wonder what that was, because I never have seen the same thing before. That may be an abscess of aortic root, or even a giant dilatation of aneurysm of right coronary artery, maybe, I don't know. And then I try to move on with another view in order to clarify, get more information about this structure. With a 5-chamber view, we can see here the continuity of likely aneurysmal structure with the right coronary curve. And then I turned to parasternal soft-axis in order to identify the normality of proximal coronary arteries. Also, I see to confirm that it is really an aneurysmal structure of right coronary curve. And now I show you the explain image that proves the connection, the continuity of the aneurysmal structure and the right coronary curve here, and its division into multiple smaller cavities inside the structure. And now with color explain, we can see easily there are two different flows. One flow comes in and comes out the structure, the aneurysm structure, and the second flow here is the significant aortic regurgitation. And now I show a beautiful image of the 3D image of the aneurysm. Here we have aortic, here we have a right ventricle, and here we have a left ventricle. And this is the aneurysmal structure that connects to the right coronary curve with the septation inside the structure. And this is another view in order to clarify the connection between the structure and the adjacent heart structure. We have here, this is the interatrial septum. This is a non-coronary curve. This is the left coronary curve. This is the RVOT, and this is the right coronary curve. And we can see here, this is the neck of aneurysmal structure that connect to the right ventricle, right coronary curve. So now we have a definite diagnosis is the aneurysm of right coronary curve that dissect into the interventricular septum. And after that, our patient was operated. So you can see here, there is a surgical photo show you this is the aneurysmal structure. And this is the bottom of the aneurysm with several smaller cavity inside. And later, our patient was removed the aneurysmal structure, and a native aortic valve was replaced by a mechanical valve. Our patient recovered totally with a good result. And that at the end of my presentation, Thank you for your attention, and I'm looking for your questions. Thank you.
Thank you, Dr. Thank you, Dr. Thuy. Please, the next topic. I would like to introduce Dr. Pham Thu Thủy, present the second topic. The second topic, the name of the second topic is the formation of the mitral aortic interventricular valve process pseudoaneurysm detected by consecutive echocardiography, no longer an incidental findings. Please.
Hello, for my second presentation today, I will talk about another rare lesion with a long medical term. It is mitral aortic intervalvular fibrosis pseudoaneurysm. So, first of all, I will talk about the anatomy of this structure. This is aortic valve, this is the anterior leaflet of mitral valve. So, this is a tiny zone with the fibrous continuity between aortic valve and mitral valve. That this tiny zone we don't mention so much on daily practice. So this is illustration can show you the fibrous continuity between aortic valve and anterior leaflet of mitral valve. So because of its special location, this tiny zone is called mitral aortic intervalvular fibrosis. So if there is a presence of animal pseudo cavity that exists between the aortic valve and anterior leaflet, so in this case we call intervalvular pseudoaneurysm. So about pseudoaneurysm of mitral aortic intervalvular fibrosis, its causes is an uncommon complication of cardiac surgery, heart trauma, or is it a quite rare developmental form of endocarditis? About its symptoms, like other infections in case of endocarditis, but sometimes it has no significant sign and usually detected incidentally. About treatment, for uncomplicated and small pseudoaneurysm, treatment can be managed conservatively. Yeah. But for large and symptomatic and complicated mitral aortic intervalvular fibrosis pseudoaneurysm, it requires invasive treatment. So this illustration helps you to understand well about the anatomy of this special pseudoaneurysm. This is the aortic, this is the anterior leaflet of mitral valve, and this is the tricuspid valve. This is coronary sinus. So this is a left coronary artery. This is the special location of the pseudoaneurysm. So when it has a complication, it may be erupt into left atrium above, but sometimes it erupts into aortic valve, into aortic lumen, and even in the worst case, it can erupt into pericardial space that leading to hemopericardial tamponade, and the worst result, of course, is death. So now I will talk about my patient. A 30-year-old male was admitted with a history of radial fracture repair 4 weeks before his hospitalization. His clinical picture showed a fever of 39 degrees Celsius, blood cultures were positive for Staphylococcus septicemia, and echocardiography was indicated in order to screen endocarditis. And it is the image from the first echo. We can see just a thicken of mitral aortic intervalvular fibrosis here, and with a mild pericardial effusion, and the other structure of the heart were normal. Unfortunately, our patient had a poor response to antibiotic therapy. So 2 weeks later, we did a second echocardio. So now, surprisingly, you can see here, there is pseudoaneurysm that the previous, the thickened mitral aortic intervalvular fibrosis developed quickly. So with the presence of a typical size, typical characteristic of pseudoaneurysm that exhibited diastolic collapse and systolic expansion. You can see here that is the neck of the pseudoaneurysm that connect to the left ventricle. So this is the four-chamber view that have you to see more in detail about the pseudoaneurysm structure and the movement of blood flow that provoke the expansion and collapse of pseudoaneurysm. And then I did a 3D echo, and now we can see here this is aortic valve, this is left atrial, and this is the neck of the pseudoaneurysm that connect to left ventricle outflow tract. And in order to get more information about the sign of pseudoaneurysms, we did a CT scan, and it is aortic, it is the left ventricle, this is pseudoaneurysm structure, this is the left atrium, and this is the dimension in of our structure, pseudoaneurysm structure. And here we can see there is a neck of pseudoaneurysm small structure. It is the aneurysm, and it is the left ventricle. And once more time, we can see here that is the aortic, it is the left ventricle, it is pseudoaneurysmal structure, and it is the neck that connect between the pseudoaneurysm and alveoli here. And that is the final of our the diagnosis is the mitral aortic intervalvular fibrosis pseudoaneurysm. So we sent him to operation. Now here we can see the image from the operation. This is a mild pericardial effusion with the presence of fibrous strain here. And when we did aortotomy, we can see that is the structure, that is the pseudoaneurysmal structure here. And finally, in order to close the connection between the pseudoaneurysmal and the alveoli, our surgeon used a pericardial patch in order to reconstruct the fibrous continuity between the aortic and anterior leaflet of mitral valve. And fortunately, after operation, our patient had a good response to antibiotic therapy, and our surgeon preserved successfully both the aortic valve here and mitral valve here. And this four-chamber view, we can see there just only a mild mitral regurgitation, and our patient recovered totally after 4 weeks. That is the end of our presentation. So my psychometrics is serial echocardiograms are necessary for all septicemia. And once more time, thank you for your attention, and I'm looking forward for your questions.
Thank you so much for Dr. Thủy for special presentations about the 1 case of the rupture of pseudoaneurysm. Now we move to next session. Next speaker.
Okay. Before move on to next speaker, there is one question on Q&A chat box to the Dr. Kana Elka. Dr. Kana Elka, are you still online?
Yes.
Yeah.
Yes, sir. I'm online.
Yeah. The question is, in female patients, if we see the dilated left ovarian vein and dilated IVC, in that case, we should check the pelvis for evaluation of AV malformation.
Yes. What, sir? Hello?
Yeah.
Yeah.
In female patients, in that case,
Yes.
in female patient, we see
Same with my case.
yeah,
Hello.
Hello.
Yes.
Oh, yeah. In female patients, if
Yes.
we see dilated left ovarian vein and dilated IVC, okay. In that case, we should check the pelvis for evaluation of AV malformation.
I explain a little bit more the question. One doctor have a question how to diagnose this malformation, arterial malformation in the pelvis. In this case, you have see the dilated of the left ovary vein and dilated the IVC, so you can diagnose the malformation of the in pelvis. So how about the criteria to diagnose this arterial venous malformation in the pelvis? That is a question of the one doctor in the online. Do you understand the questions?
Okay. Please, Dr. Elka, you can see the Q&A chat box and you can answer on chat box. Okay. I'd like to move on the next report. Next speaker is Dr. Anlan from Indonesia. She is cardiologist and her affiliation is Department of Cardiology and Vascular Medicine and Faculty of Medicine, University, Indonesia. She is clinical teacher of Department of Cardiology and Vascular Medicine, Faculty of Medicine, University, Indonesia, and she has several affiliations of Indonesian Heart Association and Indonesian Society of Cardiovascular Imaging. She published in various articles in 6 journals. She will talk about the decreased global longitudinal strain in rheumatic mitral stenosis with the preserved RV ejection fraction. Cardiac magnetic MR feature tracking study. Please, Dr. Ellen.
Global longitudinal strain in rheumatic mitral stenosis with preserved left ventricular ejection fraction, a cardiac magnetic resonance feature tracking study. The purpose is to assess LV myocardial strain by CMR feature tracking in significant rheumatic MS, mitral stenosis. Methods to the population, we retrospectively analyze LV feature tracking in patients with significant mitral stenosis who underwent CMR examination. This is a moderate and severe mitral stenosis. The exclusion criteria were significant mitral regurgitation, significant aortic valve disease, coronary arterial disease, hypertension, and diabetes. So we got 65 subjects, consists of 22 healthy subjects, 21 patients mitral stenosis with preserved ejection fraction, and 22 patient mitral stenosis with reduced ejection fraction. This is the CMR protocol that we did perform on 1.5 Tesla scanner. A stack of short axis for chamber to chamber. 3 chambers sinus views were taken with sinus sequence and expiratory breath hold. Post-processing analysis were done by experienced cardiovascular images with post-processing software to measure LV, RV, volumes, function, and LV myocardial strain. A two-dimension CMR feature tracking method were used to measure global longitudinal strain, global circumferential strain, and global radial strain. Long axis sinus were tracked to derive global longitudinal strain, while short axis sinus were used to derive global circumferential and radial strain. This is the other data. Okay. And this is the results. The subjects enrolled in the study were about 42 years old, and about 65% were female. This is the baseline characteristic of those 3 groups. As we can see here, there are different proportion for atrial fibrillation, and then there are difference value in left ventricular ejection fraction between preserved LVEF and reduced LVEF, and then a difference of right ventricular volume index here, and then right ventricle ejection fraction. And this is the main results of myocardial strain profile in those 3 groups. Yeah, we can see here. We can see here that mitral stenosis patient with preserved ejection fraction have already decreased global longitudinal strain, while the other strain were still in normal limits. Okay, and this is the post hoc analysis of the differences of myocardial strain. We can see here there was significantly different of global longitudinal strain between healthy subjects and mitral stenosis with preserved LV ejection fraction. In this plot, in the scatter plot for global longitudinal strain, we can see here the blue dots is the healthy subjects, while the green dots are the mitral stenotic patient with preserved ejection fraction. They are in the different region here, so they already decrease in the patient with mitral stenosis, even if the ejection fraction are still good. And it's worse for the mitral stenosis patient with reduced ejection fraction. While in the plot for radial strain and circumferential strain, the healthy subjects and the mitral stenosis patient with preserved ejection fraction are in the same region here. And also in this plot, also in the same region. Okay, this is the other result. We try to analyze the correlation of myocardial strain parameters with other variable in the rheumatic mitral subjects only. As you can see here, there is weak correlation between rhythm, atrial fibrillation rhythm with this global longitudinal strain, global radial strain, and global circumferential strain parameters. And then there are weak to moderate correlate correlation between the right ventricular volume index and right ventricular ejection fraction to those three parameters. This myocardial strain. Discussion: MRI has high resolution to define endocardial and epicardial border and high access to large field of view to provide the most accurate and reproducible assessment of LV volumes and function. The strains also lead to the feasibility of feature tracking applied to the routinely acquired sinus CMR images that we can acquire without gadolinium injection. So, and then it could be presumed that there was intrinsic factor that had already influenced contractile function in this earlier stage of disease. Inflammation and fibrosis process could be responsible for this phenomenon. Those three strain measurements were weak to moderately correlated with RV volume index and RV ejection fraction, could be due to RV remodeling and then lead to kinetic alteration of interventricular septum. The strain measurements were weakly correlated with atrial fibrillation because the loss of atrial contraction, it can lead to decreased preload volume and then affect the LV contractility. On the other hand, hemodynamic factors such as mitral valve area, mean mitral valve gradient, and systolic pulmonary arterial pressure were not correlated with the strain measurements. As a conclusion, global longitudinal strain was significantly decreased in rheumatic mitral stenosis with preserved LV ejection fraction as assessed by CMR feature tracking. Global radial strain and global circumferential strain were significantly decreased only in rheumatic mitral stenosis with reduced LV ejection fraction, but remains normal in rheumatic mitral stenosis with preserved ejection fraction. Thank you very much. Greeting from Jakarta.
Thank you, Dr. Alan. Okay. Thank you.
Now we move the next topic. Next topic is the value of the myocardial strain in the prognosis of the major adverse events in the non-Asci segment elevation acute coronary syndrome after percutaneous coronary intervention. The speaker is Dr. Trần Việt Hà. I would like to introduce a little bit about Dr. Trần Việt Hà, nationality at Vietnam. Her affiliations Vietnam National Heart Institute. She worked at Bạch Mai Hospital, Hanoi, Vietnam. She a cardiologist with education doctor degree at Hanoi Medical University in 2005 and resident at Hanoi Medical University in 2009. Now she had many publications concerning echocardiography. Now I would like to invite Dr. Trần Việt Hà present your presentation, please.
Hello, I'm Dr. Trần Việt Hà from Vietnam National Heart Institute at my hospital. I'm going to present my study about the prognostic value of global longitudinal strain in patients with non-Asci segment elevation acute CRO syndrome after percutaneous CRO intervention. We know that after PCI in non-Asci ACS, individualized risk stratification is one of the key issues in optimizing patient treatments, and several functional and morphological parameters of the left ventricle are available to estimate the risk of poor outcome. In today's clinical routine, left ventricular ejection fraction is the most commonly used parameter for monitoring cardiac performance and has great impact on decision making. However, it has limitations like missing information, especially in early stage of heart failure, the patient with preserved ejection fraction, but later with poor outcome. So, we do this study to evaluate the association between global myocardial strain and some major adverse cardiovascular events within 6 months post PCI in non-SDE ACS. This is the principle of spectrum tracking echo. A spectrum of myocardium on echocardiogram is described as a spectrum, and if the position of the myocardium changes, the spots will also change. And when we track the movement of the spectrum, we will track the movement of the heart muscle region as well. And based on that, we have 3 myocardial strain, longitudinal strain, radial and circumferential strain. There are many other research on myocardial strain in non-ST7 elevation acute coronary syndrome. We see that all of these studies based on global longitudinal strain, and most of them based on the diagnosis value of global longitudinal strain. Only graphic syndrome study the recovery of left ventricular function after coronary intervention in patients with acute coronary syndrome, but only 37.5% of the patients are diagnosed with non-ST7 elevation ACS. And we still lack the information about the prognosis value of strain parameters in the patients. We do this study at Vietnam National Heart Institute, Beckman Hospital, Hanoi, Vietnam. With eligible criteria, we exclude the patient with history of myocardial infarction and complete left bundle branch block, with Parkinson-White syndrome, high degree atrial ventricular block, pacemaker, patient with moderate and severe valvular heart disease, atrial fibrillation, ventricular extrasystole, and those patients with poor echocardiogram image quality, and the patient who did not agree to participate in the study. When the patient diagnosed non-ST7 elevation ACS who meet eligible criteria, and after successful percutaneous coronary intervention within 48 hours post-PCI, we do the routine echo and 2D spectrum tracking echo. Then all the patients were followed within 6 months after PCI to see the major adverse cardiac event. Major adverse cardiac events is defined as death of all cause, acute myocardial infarction, stroke, and heart failure. This is the steps we do the 2D spectrum echo. First, we have to determine the time, the aortic valve closure based on apical 5-chamber view with pulse wave Doppler, and is determined by the clicking of aortic valve closure. And then we will start the 3-chamber, 4-chamber, and 2-chamber apical view, and then the parasternal short axis view of the base, the mid, and the apex. And then we will use EchoPack of GE software to see the strain. And then at last we will have the bull eyes. After follow-up 125 patients, we have on those results. The baseline characteristic, the age is 65.5, and it's the same as the risk study of Hoài Nguyễn, 65.2, and it's higher than other studies like Tibar, Kaspar, Viola, and Asci. And all those patients, female is less than male, and the ratio of male over female is 2.5. And this is the baseline characteristic of those the patients. And we see that the number of these vessels, the one vessel disease, have the largest number, 36.8%, and the ejection fraction is 57.3%, and only 20% have reduced ejection fraction less than 50%. And hypertension, the risk factor, we see that hypertension has 73.6% and the highest level. Next, smoking. Obesity, only 8% of the patient. And after 6 months follow-up, we see that the event was 15.2%. That 2 patients died, which 1.6%. And here we see that among cardiovascular event, heart failure after intervention was the most common, 9.6%. And this is the baseline patient characteristic of all patients. Characteristic, we see that the group with MACE, all the parameters, GLS, RS, strain rate, longitudinal base, mid apex, and global circumferential strain and global radial strain in the MACE group is much more worse than the group without MACE. And we use the ROC analysis, we see that global longitudinal strain has the largest area under the curve, 0.945, larger than ejection fraction and race score. And with the cutoff value of GOS, negative 15.45%, GOS has sensitivity and specificity is 84 and 90%. And with the cutoff value of 0.905, GOSR has sensitivity and specificity 84 and 88.2%. And we also use the univariable and multivariable causal presence for MACE. We also assess all other parameters: age, diabetes, troponin T, NT-proBNP, race score, TIMI score, GLS score, GOS, GOSR, global circumferential strain, and radial strain. We see that age, troponin T, NT-proBNP, race, GLS, GLSR, GCS, and GRS has the prognostic value. And when we use the multivariate analysis, only GOS after percutaneous scoring has the prognostic value with hazard ratio is 1.72. And when we use the Kaplan-Meier estimate the probability of event, we see that the group with GOS less than 15.45% is better than the group with GOS with more than 0.45%. And the author Anthony also have the cutoff value of GOS with negative 15.4, and the risk of all-cause mortality with hazard ratio is 4.5. And we conclude that GOS, global longitudinal strain, 48 hours after PCI has predictive value of major adverse cardiac event within 6 months in patients with non-ST Chapman elevation, acute coronary syndrome with hazard ratio is 1.72. And with a cutoff value of negative 15.45%, the GLS within 48 hours post-PCI had a sensitivity and specificity of 85 and 90% respectively in predicting several MACE within 6 months with an area under the curve of 0.545 and greater than ejection fraction and race score. Thank you.
Thank you for the nice presentation of the Dr. Pitchin. So this session, we have a few minutes to discuss about the 8 topics in this morning. So please, audience in the online conference, have a question to discuss and have a question or have a comment about the a topic of the speaker.
May I have a question for the last presentation of Dr. Chị Việt Hà?
Please.
Yeah. In your conclusion about the final result of a global trend after that you did the echo after 48 hours after the percutaneous coronary intervention. So why did you choose the threshold is the 48 hours instead of another limit such as the 24 hours or 36 hours? Thank you.
Please turn on the micro.
Do you listen me clearly? My question.
Yes, we heard now. Now we cannot hear from you. Please turn on the microphone.
Yeah. Can you hear me?
Yes.
Yeah. In our study, we choose 48 hours. It doesn't mean that the exact 48 hours. It means within 48 hours because before the patient can go home. You understand? It means that within 24 to 48 hours on the patient after PCI, they can get out the hospital. So we choose 48 hours. It means that when the patient is in the hospital, within the patient is still in the hospital. Yeah. And that's easy for me to do the echo.
That's clear. So this is in time at 10 o'clock. So on behalf of the panelists, chairpersons, I would like to thank you so much for every speaker in this sessions. This session we have many topics, very interesting. For topics concerning the spectral tracking echocardiography and some case study concerning the intervention, very interesting. So on behalf of organizer committee, one more again, I would like to thank you all of us. Thank you for the audience in the online meetings and hope you in the next meeting in the next year. Thank you.
Thank you.
Thank you.
Thank you.
Thank you so much. Nice. Yeah.
Bye. Have a nice day.
Or you soon later.
Have a nice day.
Have a nice day.
See you.
See you.
One day, we can all stay healthy, and no one suffers from hunger. We will only realize this vision together. Together, we will come back stronger. Together, for a future with health for all, hunger for none.
My journey continues, and I know I'm not alone. Because together we can make a difference every day.